Good morning, everyone, for a few more minutes this morning. Shaare Zedek is honored to have Dr. Lustbader here, who's one of our guest speakers today. She is Chief Medical Officer for Supportive Care, Chair of the Department of Palliative Medicine at ProHEALTH, and Professor of Medicine at Hofstra Northwell School of Medicine. Dr. Lustbader is a board-certified internal medicine, critical care medicine, and palliative medicine physician with extensive experience in caring for people with multiple chronic conditions or advanced illness. She received her medical degree from the University of Wisconsin-Madison, did her internal medicine residency training at NYU Bellevue, and her fellowship in critical care medicine at St. Vincent's Hospital in New York City. A national expert on population health and advanced illness care, Dr. Lustbader provides medical care to homebound seniors with chronic medical conditions with in-home visits and telemedicine. So beautiful. She also works with the Center for Medicare and Medicaid to develop alternative payment models for health care, particularly as they relate to the care of seniors at home. And she also works with the National Center for Quality Assurance to develop national quality standards for home-based care programs. It is our pleasure to welcome Dr. Lustbader, who will speak about caring for aging parents or those with serious illness. Thank you, Dr. Lustbader.
Thank you, everyone. It's a pleasure to be here. Just coincidentally, my son, who is studying in Israel this year, was at Shaare yesterday visiting the sick with his group of other colleagues who are learning together. On the way over here today in the Uber, I got two calls on my cell phone. One of them was from a daughter of a Holocaust survivor in Brooklyn. She's caring for her mom. Her mom has serious pain. She has a mass in her abdomen, probably pancreatic cancer, but we don't know for sure because we haven't biopsied it. The daughter's called me several times before. Should we work this up? Should we not? Mom has been through a lot. We really don't want her to suffer, but we feel like we're not doing enough if we don't find out what's in her belly, what's causing the pain. Should she get treatment? Should she get chemo? What should we do? Her doctors, for the most part, feel she's too frail to tolerate the workup for the cancer, and she's also quite symptomatic, has a lot of pain and nausea. So we had started her on some pain medicine, an opioid, a strong painkiller, which is very appropriate when people have pain related to cancer. We also started her on some medicine for the nausea. But the burden on the family member, on the daughter who's caring for her mom, who constantly feels she's not doing enough, not fixing it, not working her mom up, feeling like maybe she's failing, is really eating away at the daughter, even though the patient is just too sick to tolerate any further workup. And sometimes we come to a point in medicine where we can't fix everything. And even though there will be a doctor, there I'm sure are doctors who would do a biopsy, take her to the OR, open up the abdomen. Sometimes when we do that, we cause more harm, or we steal people's time. They don't get to go back and be with family. And so that was one call I got in the Uber just on the way here today. The second call came from a random stranger, a U.S. Navy SEAL in Virginia. He's caring for his mother somewhere in New York City, and his brother is trying to figure out what to do with her because she has advanced dementia. He said, how did you get my number? He said, well, I Googled you, and there was something on the Institute of Medicine where you gave a talk, and at the bottom I saw your cell number on a slide, and I called it. And I said, well, I'm really glad you called, and let's think this through together. I'm in an Uber, we have time. And so we ended up talking about how to get his mother a private hire home health aide. He thought that insurance or Medicare provided those. A lot of people think that, when in fact that's really not the case. So we're going to talk a little bit about some of these practical things that come up that we're not really well prepared for. So these are just two examples today of things that can come up that we're not really well equipped to handle, and quite honestly, the current healthcare system doesn't do a good job with.
Something new?
Yeah, so we'll talk today about the care gap, which is this place where people are really, really sick. They don't just have a cardiac disorder or hypertension, but they have a lot of other things or a serious or advanced illness. and they're not really sick enough or dying to benefit from hospice. So they're in the middle, and they're really sick, and probably many of us in this room might be caring for a family member who fits into that spot. We'll talk a little about the burden on family caregivers, particularly on women, and then I'm going to give you some pearls on advanced care planning, what you need to know today to get this right. And then I'm going to clarify for you what hospice is and what palliative care is. So we'll first talk about the care gap. And again, when someone has one thing wrong with them, like hypertension or one disease, we do a really good job in medicine in trying to address that. If you have diabetes, we know how to follow the hemoglobin A1C. If you have celiac, we know how to help people stay gluten-free and measure those blood tests and do those kind of biopsies to treat that one disease. But if you have multiple chronic conditions like dementia, heart failure, some frailty, a little bit of weight loss, hearing deficit, visual impairment, and you're declining functionally, the healthcare system and going to a doctor's office isn't really going to get you exactly that whole person care that you need. And very often patients are sent to the hospital when they could be better cared for at home. The reason it's so dangerous to go to a hospital, unless you need an operation or an ICU, is that we make mistakes. We especially make mistakes with frail elderly people. So if you have a loved one who's in the hospital, never leave them alone. Always have someone at the bedside with them. They get better care. We pay more attention to people when there's someone there, and we're less likely to make a mistake with a medication or something else. Also, elderly people get confused in the hospital. Hospitals are really noisy. They've looked at the decibels in hospitals with the rolling cart, with the bells, with the alarms that go off. It can be 90 decibels in a hospital. Really could cause some hearing deficit if you just have that noise all the time. Very hard for elderly people because their day-night cycle is disturbed and they get delirium, a reversible sort of mental disorder from being bedbound, being in a hospital. They're also at risk for falling. Even when we put the side rails up, they just fall over the side rail, but 8 inches higher than they would have if they just rolled off the bed. So side rails are dangerous too. And we try not to restrain people because that makes them very agitated. And so we really don't want to do that. And we certainly don't want to sedate people because that makes them less able to mobilize and get out of the bed. So if someone you love is in the hospital, it's always safer to have someone there 24/7 taking turns and shifts. Going to the hospital also has the risk of infection. The things we worry about most is C. difficile, which can cause diarrhea, and also MRSA, methicillin-resistant Staph aureus, and other bacteria in the hospital. Because we use so many antibiotics there, people are at risk, and you can get that from skin to skin, on a doctor's necktie there's contamination, even on the stethoscope. So we always want to make sure we wash our hands when we enter a patient's room, but even with all of those safety guards in place, there can be contamination and the risk of infection. So if we can treat someone at home, we always would prefer to do that. The other thing with the care gap is that patients who are not yet hospice eligible need a lot of extra support at home. And we need services 24/7 at home. And hospice certainly provides that, but to get into that kind of a program, you have to be terminally ill, you have to likely die within 6 months, and you have to give up other treatments related to the disease. Hospice is perfect care at home, but it's only for those final 6 months of life. We can re-enroll someone in hospice, so at the end of 6 months, a doctor can say, I still want them to get that wonderful care at home. I'm going to recertify them for another 6 months because they're still really sick. And sometimes people live longer and do better with hospice, so we can re-enroll them again. It's a Medicare benefit, and a lot of people are afraid of the word, so they don't get the benefit they deserve. It's really one of the few things that healthcare does perfectly by providing doctors, nurses, social workers, and all the medication into the home. But you do have to be very, very sick, and a doctor has to think that you might die of your illness in 6 months, and they can again recertify it for another 6 months. It's also a great way to get home health aides because hospice does provide those, sometimes even 4 hours a day. So it's a very good benefit. But most people aren't there yet. They're in a space we call the care gap, where they're too sick, but not sick enough for that. So as many of us know, our current healthcare system is in crisis, and we spend about $11,000 in this country for every man, woman, and child in the United States. It's gone up every year, and we are ranked probably 37th in developed nations in terms of quality, meaning how easy is it to reach your doctor, how accessible is healthcare, how are we doing in preventative medicine, infant mortality, maternal mortality. We rank very low. We are also aging, and so in 2050, the number of Americans is going to double. And so we're going to be caring for a very aging, older population with a healthcare system that's currently based on rewarding physicians and hospitals to do more stuff to you. That's currently the payment model, so that the more we do to people, the more is made. Other countries reward wellness. So by keeping a population healthy, that is the reward. And we're starting to see a shift in the current healthcare system in terms of how healthcare gets paid for to move more toward outcomes. And so as Medicare, the largest payer, decides how they're going to pay for Medicaid and Medicare, they're going to start rewarding on outcomes. So for example, a doctor who treats diabetics will get paid more money if his or her patient's hemoglobin A1C, their sugars, are down, or if their weight is down and their cholesterol is down. So if that doctor does a better job, they'll make more money. As we move more toward rewarding outcome, the cost of healthcare hopefully will come down instead of rewarding doctors to just do more echoes to people and more tests. Because that's currently the model, and it's just misaligned. We want to make sure we're keeping people healthy and rewarding that. The other thing right now is that the sickest 5% of people account for about half of the spend. So a really small number of people are accounting for half of our spend. And that's good. Certainly we want to spend more money on sick people, but 1/3 of the spend, 1/3 is waste, meaning it's going to paperwork, bureaucracy, administration. It's not helping people. And so as we start to think about overhauling healthcare, we obviously want to get rid of the waste and redundancy. We want to share electronic health records so you don't have to repeat all of your tests at NYU, and then you go to Columbia, you repeat them again, and you're seen out in Long Island, and it's repeated yet again. So we really want to make sure that records are shared. It's really important that everybody has copies of their healthcare records, or someone that you love. So if somebody's very sick, that you have copies, or you keep a Microsoft Word document of everything that's happened for them, as well as all their medications. Because when you go to the doctor, don't assume that they have that. It's really great when a patient shows up and they've got something in writing that kind of outlines what's gone on and where those records might be, as well as all their meds, including all the dietary supplements people take. A lot of times people purchase things in different stores. A lot of things are popping up. All of that should be written down because a lot of that stuff is dangerous, especially in the setting of renal impairment or liver impairment. So the doctor needs to know even about the dietary supplements, especially if you're caring for somebody who's elderly. There's a myth about free home health aides, and this is probably the most common myth, that because somebody's really sick and they need help at home, that somehow insurance companies or Medicare is going to provide home health aides, and that's just simply not true, unfortunately. There may be changes in 2021. We're working very hard in DC right now to change that. So, for example, certain Medicare Advantage plans may be able to offer, as a health benefit, home health aides if patients meet certain conditions. So in Medicare, the health insurance for people older than 65, we can have straight fee-for-service Medicare, which most people have. Then there's Medicare Advantage, which some people choose to have. 20-30% choose that. That can be offered by Humana or United or Aetna. So it's looking like it may be in 2021 some of these Medicare Advantage plans will offer to certain patients who live alone with a serious illness a home health aide. Otherwise, the burden really falls on family members to provide home health aides. Whether you pay for them privately, you can go through an agency, The best thing, of course, is to not go through an agency and just hire them. And the reason for that is then they become your employee, they're like a family member, and they can do stuff like dispense medication. They can do medical tasks. If there's a colostomy or a Foley catheter or something that needs to be changed or addressed, they can do stuff like that for you with proper training. But a home health agency person can't really do stuff like that, and they're much quicker to call 911 when something can be safely treated at home because they're just worried about the home health agency getting upset with them or firing them. So if there's any way you can hire someone very trustworthy, a housekeeper, somebody's friend, somebody else you know, that's always better because they're your employee and they can do things that they are trained to do. We service now in the home about 2,000 very sick people in Brooklyn, the Bronx, New York City, and Long Island, Queens. We have a house calls program that I run, and whenever we come across a privately hired person who's not through an agency, it's jackpot for us because they're our partner in caring for somebody who's elderly. We can partner with them, we know that they'll call us, they want what's best for the person they're caring for usually, and so we can have a strong partnership that way. This is a terrific story that highlights, I think, the crux of what's going on here. Nina Bernstein wrote this in the New York Times in 2014. This is about Joe Andrew. This is a patient who's 91 in this photo. And he, in 1927, when he was 5 years old in New York City, his mother sold him to a vaudeville act because she was too poor to take care of him. And then when he was about 12 or 13, she was able to take him back. She had gotten some means to raise him. And he's here in the hospital, in a New York City hospital, with his daughter Maureen, who desperately wanted to get him home. And unfortunately, Mr. Andrew spent 8 months and 8 days between hospital, subacute rehab, hospital, different subacute rehab, and eventually briefly home, and then back to the hospital again. And this story highlights how difficult it can be to grant someone their last wish, which might often be to stay at home. But the burden on the daughter is so great. But there are ways that we can help people stay at home and plan to be at home if that's their goal. And one of the key things certainly is to make sure you have access to private hire home health aides, that you live in a place that's on a bus line so that the home health aides can get to you. We cannot, for example, in Long Island, get anyone to Glen Cove. There's no bus line there. The aides can't go there. So it's very important that where you choose to live, if you're aging or caring for someone who's aging, that people can get to you, whether it's on a train, subway, or bus, that these aides need to be able to get to you. That documents and things are put in place, which we'll go over, that make sure you can also leave a hospital and get home. And again, most people prefer not to be in a nursing home. They are very difficult places to be. The sounds, the smells, everything's very unfamiliar. Most people, 85% of people, when asked, say they'd rather be at home if they could, but very often people end up in a nursing home because they don't make plans to protect themselves from going there. Again, the burden of helping to care for somebody falls on family caregivers, and most family caregivers are women, especially women of color, and women give up a lot, sacrifice a lot to care for someone. How many people in this audience are caring for somebody now, or have someone that they've cared for recently? Yeah. And it's hard. It's really a hard job. People who are family caregivers rarely feel valued. Many have anxiety, depression, PTSD afterward, or feel like if they had done something else, their loved one might have had a different outcome. Just like today in the Uber on the way here, the daughter of the Holocaust survivor feeling guilty that they didn't work up a mass in the abdomen, even though the patient has lost 30 or 40 pounds, would have died during any kind of diagnostic procedure, isn't a candidate for that, certainly wouldn't tolerate any chemotherapy. And so there's tremendous guilt and burden that family caregivers suffer. This was one of my patients who I saw recently who came in, and this is just one of the things one of the caregivers showed me was just how meticulous she is with keeping track of medication of her dad that she cares for. And so just writing down all of these things and all the note-taking and the documentation that can go on with family members who are really trying very hard to do a good job caring for a loved one. There are also a lot of medical tasks that family caregivers have to do, like bathing, toileting, dressing, which can be very difficult for family members to do on someone they love. want to talk about advanced care planning, and this is a very important topic. Raise your hand if you have a healthcare proxy form filled out for yourself. Okay. A lot of people, but not everybody. And how many people who raise their hand have given that form to the healthcare proxy they chose? Okay. So, very few. Okay. So, how about giving it to your doctors? One. Okay. Okay, great. So, healthcare proxy form, and at the end I'll give you the website. They're free. You can download it and print it out. Most important thing, every single person over the age of 18 should fill one out. Really simple. All you do is go to the website, you download it, and you complete it. And the reason it's really important is that if ever you have something that happens to you and you're not able to speak for yourself, there's a hierarchy, which I'll go over, which you may not like, and you might want to choose someone else. So it's really important that the healthcare proxy form is filled out and that you give a copy of it to the person you've chosen and all your doctors, so that they have a copy and all your doctors have a copy. The second thing is a MOLST. Has anyone heard of a MOLST? Okay. Medical Orders for Life-Sustaining Treatment form, and that's a really important form for someone who has a serious illness to have. Living wills are always bad. Always bad. Why are they always bad? They're written by lawyers. They're really long. They're not a medical order. They're not actionable. They're often tucked away somewhere. They might be too specific. I've had people produce living wills. I was chief of the ICU at Northwell for many years. I had people bring 20-page living wills that spelled out all kinds of things, but not the situation the patient was in, because it was written 20 years ago. It didn't anticipate what we could do today. They didn't realize we could do continuous dialysis on people, on a ventilator, on blood pressure medicines. We can do that now. We can do transplant. We can put people in beds that rotate all around and then perfuse their lungs in ways we couldn't 15 years ago. So when you write a living will and are very specific with what you want and don't want, things change in 5 years and it's never moving. A healthcare proxy, a person you pick, can hear the information in 2019 relative to you, pertinent to you, and make a decision that you would want today. So never ever rely on a living will. It's not wrong to have it, but it can be harmful if it goes against what we might be looking at today. So sometimes we've had people produce them, but it might not have anticipated that we could do something, and so then we're sort of stuck because we can do it, but the spirit of the living will wouldn't have wanted it, but we're a little bit stuck from a legal perspective, especially if the patient doesn't have a healthcare proxy form completed, then we're sort of stuck following that. So really no need for them at all if you have a healthcare proxy form filled out and your healthcare proxy could make decisions on your behalf because they know the kind of person you are and they know what you want and value. So, how do we pick a healthcare proxy? Well, it's not always your spouse. Necessarily, they might be too frail, upset, stressed in a crisis, so maybe it's somebody else. It could be your spouse. You pick your proxy and an alternate person. You want somebody who's going to handle stress really, really well, so that if we get hit by a bus or something, God forbid, on the way home, that somebody who's going to handle that trauma and stress can rise and hear things and make decisions on your behalf regarding life-sustaining treatment, what you want and value. Do you want to go to rehab? Should you go to here or there? Is chemotherapy appropriate? If you're on a ventilator and not likely to come off, what would you want? That person who can really make choices that you would want if you're not able to, with the information the doctors would provide to that person. So it's really got to be a person who's reliable and can make really good decisions for you. It's not always your spouse. If you fail to make out a healthcare proxy form, if you don't complete this and give it to somebody and have it available during a crisis, New York State has a hierarchy, a default that's already in place. That's who we would go to anyway. They're not called a healthcare proxy, they're called a surrogate. And so we would go to your, quote, legal surrogate, which is what New York State mandates us to do for information and consent on how to treat you. So if you have a legal guardian, that's always who we'd go to first. And then certainly we go to spouse or domestic partner. So domestic partnerships actually count here. This is new as of a couple of years ago in New York State, where that is recognized. Gay, straight, doesn't matter. You're in a domestic partnership, you live with someone, you share a puppy, you have a car, you're committed together. That's a domestic partnership, and we will go to that person over your adult children. Over your adult children. So it's really important to recognize that that domestic partnership would trump any going to adult children, which sometimes upsets adult children who want to have a say in your care, because now we're going to the person you live with. So that's why it's very important, if you don't like that default, to designate somebody else and that hierarchy that you want. We then would go to a parent, if you have one alive, if you don't have adult children, and then we go to sibling. If we don't have anybody, we then would try to find a close friend, neighbor, somebody at the shul, somewhere else, we'd find somebody. But that's how the default hierarchy would be, and we go exactly in that order for all medical decision making if there's no healthcare proxy filled out. Questions on that? Yeah.
If you don't have a director, and your life is being sustained by artificial hydration and nutrition, and there's a proxy appointment, there's a dispute between proxy, let's say spouse, partner, and adult child, what happens in your life?
It's a great question. So the question was, let's say you're on life support and there's a question regarding artificial nutrition and hydration or any other life-sustaining measure, and we have a healthcare proxy, and we have, let's say, the adult son, and they're not in agreement. Which trumps what? How many think that the proxy trumps the son? Yep. Even though the son might be really vocal and bring in a lot of support, or the daughter, or the family, the healthcare proxy trumps everything. The healthcare proxy has legal authority over everything. And that's, again, why it's so important for a parent or you in the audience to pick the right person who would make choices as though you were present in the room hearing the information about prognosis, risk, and benefit to different therapies, so that that person can make choices on your behalf. So pick someone who knows your wishes and would honor and respect your wishes. It's really important. Yeah?
Can the healthcare proxy be, let's say, for example, multiple children? Can you split it across?
So the way the New York State form is, you pick one person who's the spokesperson for the group plus an alternate in case they're not reachable. You can tell that one person, look, I'm picking you. I want you to take into account your siblings' perspectives, but you be the voice for everyone. You could say to them, you know, I mean, I have 5 children. I could say to one person, you know, Jenna, make sure there's consensus that 3 out of the 5 of you agree. I could give her specifics even like that. You can even write stuff like that down on the healthcare proxy form, or tell your proxy how you want them to handle discrepancies or different perspectives amongst the siblings. That would be in your discussion with them. But you really can only pick one person and an alternate. It's a good question. Yeah.
This is for New York State. What if you have a parent or someone that you care for that's out of state?
Almost every state has a healthcare proxy law. They can vary by state, and what varies most is the hierarchy. New York State was very late, for example, in the domestic partnership recognition. That only passed a couple of years ago because particularly gay partnerships were not recognized. And so people could have been together for 20, 30 years, but somebody else would make decisions. And so that's why it took a long time in New York to finalize the hierarchy here. But almost every state would have that. And when you bring the form to another state, it's recognized. Yeah. Yeah.
Will you be discussing DNR?
Yeah. Good point. Will we be discussing DNR, do not resuscitate? Yes.
You mentioned a MOLST. Who would prepare a MOLST? Is
Uh-huh.
that an attorney? Or I've never heard of it before.
Great, I'm glad you brought that up. I'm going to jump right into the DNR and the MOLST. It's a perfect segue, thank you. Just before we jump into the DNR and the MOLST, I want to just remind you what we need to think about when we appoint a healthcare proxy. And that is, we want to make sure they know what our values are. So we might want to tell them, I love eating chocolate. That really matters to me. If I can't eat chocolate or see my grandchildren, life wouldn't be worth living. I want to go to a graduation. If I can't really do that sort of thing, it wouldn't be worth living for me. I don't want to be a burden to others. These are the kinds of discussions that would happen as we choose no hope of recovery. We need these other ways to protect people from the kinds of things we can do in an ICU. ICUs and these treatments were intended to be used when there was hope of recovery, but they're often used when there isn't any hope at all. A medical order for life-sustaining treatment form, a MOLST, M-O-L-S-T, is completed by a doctor for someone with serious or advanced illness. And it's pink. And it usually stays with the patient, and it's best if it's kept at home if someone is at home with a serious or advanced illness. And it's a do not resuscitate order that says if I am found dead or die, don't bring me to a hospital. Or if I'm really, really sick, don't bring me to a hospital at all, try to treat me at home. So for example, the Holocaust survivor, the daughter who called me today on the way here, we did this for her mom. She has this at home. It's pink, it's on the fridge, so that if anyone accidentally calls 911 and they respond, they'll see it and they'll leave her at home. They know she's 91, she wants to be at home. There's nothing we could do for her in the hospital. Actually, we could do a lot more for her at home. They'll actually be able to leave her at home. If she happens to pass away at home and they find this here, they won't have to bring her to an emergency room to pronounce death. It will allow her to stay at home. The Hevra Kadisha can come, the shul can be called, funeral home can be called. She can go right from home there. Without this, unfortunately, many people go to an emergency room for death pronouncement, and then it can become a medical examiner case because someone died at home. Without this, how did they die? If it's over a weekend, you won't get the body until Monday or Tuesday. It's a big mess. So it's really important if somebody's really sick and their wishes are to have a do not resuscitate order, no CPR, no aggressive measures during dying, this is the only way we can protect people at home. Yeah. For dementia and Alzheimer's, right? So dementia and Alzheimer's, Alzheimer's is a form of dementia, many forms of dementia, vascular dementia, all kinds of reasons people have cognitive impairment. And to your point, as we are aging, many of us are going to have dementia and suffer that over a longer period of time, 8 to 10 years. What people don't know about dementia as it progresses is it's a terminal disease. And the way people pass away from dementia is they stop being able to swallow, and they stop eating, and they start to aspirate, and they develop aspiration pneumonia. And the number one cause of death in dementia is pneumonia. And people sometimes want their loved one to eat. Why won't they eat? Eat, try to eat. But they have dementia and they're dwindling because of the disease. It's what it does to the brain. People lose their appetite and they stop eating. And so it also is a disease, a serious illness, and when people stop eating or drinking, or they become nonverbal, they're not talking, or they're incontinent, we start to know that these are the advanced signs of dementia. No treatment for it right now, other than preventative, staying active, doing mind games, playing games, really staying active, having purpose in your life, staying socially connected can prevent the onset of dementia. But for people with advanced stages, it's important to get these forms in order. What is palliative care? So palliative care is an extra layer of support that we provide to people with a serious or advanced illness. And it can be provided at any stage of the illness. So people who have any sort of advanced illness can get palliative care, and they can even be cured. We have patients who are going through chemotherapy. I have a lot of 30-year-olds and 40-year-olds getting chemo that I see in my office for nausea, pain, and symptoms, but they're going to be cured. They're going to have a chronic disease or be cured completely, but I see them during treatment for very severe pain and nausea. We use a lot of medications, medical marijuana, other kinds of drugs to treat their pain and suffering so that they can get through it and go on and live hopefully a wonderful life. There's also hospice, which is for the end of life, and that is also palliative care, but for people who are likely to die in 6 months. It's underutilized in this country. The average length of stay on hospice is 7 days. It's a 6-month benefit, and a lot of people don't like the word, but it's a perfect program. It provides care at home. It's fully covered by insurance. You do have to give up seeing all your other doctors, and you get care at home. Doctors and nurses come to the house every week, but you don't get to go to see all these other doctors because there's nothing that is going to help the course of the disease. This was an important study published in the New England Journal of Medicine that looked at the role of palliative care in a group of people that had metastatic lung cancer. And this is really one of the pivotal studies that showed if we treat symptoms, depression, insomnia, nausea, people live longer. So people that got palliative care and cancer treatment at Harvard compared to people who got regular care, they actually lived longer in the treatment group with palliative care, 3 months longer, 12 months versus 9 months. They also had less aggressive end-of-life care when they were in the palliative care arm. But what was most important was that their quality of life improved, their depression was reduced, and they lived more. So it's not really surprising that when you treat symptoms related to serious illness, patients often do better. We're in the middle now of an opioid epidemic, which is unfortunately having a negative impact on people who truly need it. And so I have patients who have very severe bone metastases who are relieved by oxycodone or the long-acting OxyContin and need that to function and get around. But because we have this opioid epidemic, sometimes well-intentioned family members might say, you know, don't take that pill or that's addicting. It's the opposite. People who have pain related to an advanced illness should take it so that they can actually live longer and do better. Now we're running out of time, so I'm just going to jump to a story and then we'll open it up for questions. So this is Irving, who lived in New York City with heart failure and kidney failure, married for 65 years. This might look like some of your parents' medicine cabinets and kitchen tables. This is an expired albuterol inhaler from 2008. But we find a lot of these things when we start to go through our parents' pill sections in the bathroom and kitchen. And often they can be hoarders and they don't want you to take the stuff away. But very often when we do go into the home, if you're able to clean this stuff up, people can live longer and better when we reduce a lot of this stuff. So what we were able to do with Irving was to actually optimize his medications, treat his heart failure. He was enrolled in hospice for 6 months where they brought in the oxygen. They also gave him a medicine to improve his energy level. And he never went to the hospital or emergency room for the final 365 days of his life, not even once. He really had perfect care. These are 2 books I highly recommend if you're interested in the topic. Atul Gawande's book, Being Mortal, #1 bestseller on the New York Times list. And then When Breath Becomes Air, a very inspiring book about a surgeon, a neurosurgeon at Stanford, who got lung cancer. He describes his journey, and he passed away at the age of 37. His wife, also a doctor, they decided to have a child before he passed away, and they have a little girl. I'll conclude with a couple of resources for you. And again, I'll be happy to stay after and take questions too. But these are some wonderful resources. I know the question on Alzheimer's was brought up. Compassion and support. This is the link to download a PDF of the healthcare proxy form. And then if you're curious about getting a MOLST, you can go to the MOLST website and download that form or ask your doctor to complete that form for you. Again, everybody should have a proxy form. And people with serious illness should all have a MOLST or pink form in their house. We have time just for a couple of questions that folks have. Yeah.